main pumping chamber of the heart. So it's blood coming in from the lungs, getting dumped into the left ventricle.
Mm-hmm.
And both of those valves have some degenerative disease that have caused the leaflets to calcify and fuse together. So those valves don't open as well as they used to.
Well, I expected at this age that to happen.
Yeah. Well, and it is a disease of aging.
Yes.
You know, you didn't have rheumatic heart disease or
No.
things like that early on. It's just that you'd lived long enough to get there. Now, I will say both the mitral and aortic stenosis are moderate in severity. They're not critical.
Mm-hmm.
And they've been there a while. So if you look back at your ultrasound that we did 2 years ago, the measurements were pretty much the same. So I don't think that's really the limiting factor, although it is another factor into all your other problems. So, and then you have some enlargement of the aorta
Mm-hmm.
above the aortic valve. So there is some aneurysmal dilatation of the aorta. Again, I don't think that's severe, but it looks like it is moderately enlarged.
Mm-hmm.
So as far as, you know, what brought you into the hospital, I think part of that was your heart was racing, and because you have this blockage, you know, it put enough stress on your heart that we saw that you had a light heart attack. Okay.
And of course, I did have a lung that was filled
Yeah,
so that I could hardly breathe.
right, and so you have some congestive heart failure
Had
and,
pneumonia there.
well, pneumonia and or heart failure. It's,
Well, actually, I thought that myself when I was having the problem. It was in here and
Right.
one down there, and I thought maybe it was more the heart
Yeah.
than anything else. So
were you running fever,
no,
or were you coughing a lot?
no,
I mean, I know we're treating you for pneumonia, but
I know,
you know, it's based on a chest X-ray more than on your clinical presentation.
sure.
So, so that's that's basically what we've got to deal with, and then that's on background of the fact that you have a pacemaker and you've had atrial fibrillation and you've been on the Coumadin to help reduce your risk of stroke.
Right.
Now, leading up to all this, had you been having any chest pain or
No,
trouble breathing at all?
no.
Yeah. So,
You know, I do walk maybe a block or two during the day, and of course, then my heart just palpitates, gets up to about 90 or so, you know,
Uh-huh.
and, but
Well,
I do that because I think I need the exercise.
well, if you're out walking, your heart rate should go up to 90.
Yes.
So it should come up some.
Mm-hmm.
It doesn't sound like it's getting overly fast,
Right,
except when you first came in the hospital.
right.
So, in looking at your options for treatment of this, there are really kind of three general categories of treatment. One is surgery, one is to treat the blockage that you have with a stent, and the third is to treat you with medication. Okay? I would eliminate surgery right off the bat. I don't think you're a candidate for surgery.
I don't think so
I
either.
don't think you would get through surgery, or if you did,
Right.
you wouldn't get through very well.
Right,
And really, to fix all these problems, you would need 2 valves replaced, your aorta grafted, and bypass.
that's
And
understandable.
that's hard even on a young person. So I really don't think that surgery is an option for it, and I wouldn't recommend that. I think the other choice is more difficult. You know, it's between trying to treat that blockage with a stent and then treating your other disease with medications, as we've been doing, or just to treat you with medications alone.
Well, if it was a stent, they'd have to go back in doing what the process what you did today.
Right,
That's what I thought.
right.
Yeah.
So, yeah, so let's just talk a little bit about what a stent would involve. So it'd be done like we did today,
Mm-hmm.
with catheters. And what you would try to do is put a wire down across that blockage to give you purchase of it, and then probably dilate the blockage with a balloon and then try to put a stent in. Okay, that's a very simple way of putting it.
Yes.
It's more complex than that because of your other factors and the location of the blockage particularly.
Right.
As I drew a picture for your son earlier, I still have that, by the way. So this is kind of a diagram of your coronaries, and this is the right coronary supplies the back wall. This is the left coronary, which gives the LAD to the front of the heart, and then a circumflex to the side of the heart. So this blockage is right at the origin of the left anterior descending. And the reason that is important is because where do you land the stent? Okay, if you try to really finesse it, you try to put the stent right at the mouth of the vessel, and not have any stent hanging out this way.
Right.
That could compromise this. I can tell you that that's sometimes we see we can see a little landing zone where there's just enough normal vessel before you get the blockage that you feel pretty confident you could nail it with the stent. In this case, it's very hard to tell that. I think it would be a very close call. You know, in some views it looks like it may be a pretty straight cut across, but we know that in reality these vessels are usually angled. So if it's angled, you may end up having some stent struts too far out or too far in, and either don't cover the blockage adequately, or you have stent coming back into the left main coronary. And the concern for that is that you could potentially compromise the side branch. Okay. Now, sometimes what we end up doing is we just extend the stent back into the left main and realize that, you know, this branch could be compromised, but because the stents are basically open cells, you know, we could probably get away with that and just you stent over the side branch, and but you don't try to finesse this and miss the lesion.
Right.
You know, there's also calcification in this blockage, and sometimes that can make stenting a little more difficult. If the lesion is very calcified, it won't expand well, and then you put a stent in, and the stent's crimped in that artery rather than expanded.
Right.
And sometimes we will actually try to modify that plaque with atherectomy catheters or things like that, where we can drill the plaque a little bit and get it to expand better. A lot of that, I think, would be, you know, you would expand it with the balloon and see if the balloon expands. If the balloon doesn't expand, then you need to do something about it.
Sure.
So that's some of the technical factors dealing with putting a stent in. You know, I think compared to most of the stents that we do, it is going to be a higher risk procedure because you have the valvular heart disease and you're 90 years old.
I know.
We have to fully anticoagulate you during the procedure, and you would have to take antiplatelet therapy in addition to that. So we're talking about aspirin and Plavix to protect the stent. Over time, that's going to increase your risk of bleeding because you also need to be on Coumadin.
Well, I've been told, you told me I should not take aspirin
Right,
with Coumadin.
because it increases your risk of bleeding.
Yes.
Now, sometimes we run into this scenario and you have to make a decision about how you're going to do that. I mean,
Right.
most of the time when we put a stent in, we put you on all three, at least for a short period of time. And then, you know, maybe after a month you can peel the aspirin off, but then continue the Plavix and Coumadin. That's not a perfect scenario. The other option would be to stop the Coumadin and just put you on antiplatelet therapy. That doesn't give you as much protection against a stroke.
Right.
Okay, so those are the trade-offs. The other aspect of this, because it could potentially involve the left main coronary artery, you're involving a very big territory, and if things went south, that could be a really bad thing. And you know, you could risk dying, you could risk having a heart attack, and you know, again, sometimes if we run into problems, our bailout is to go to emergency surgery. Well, you wouldn't do well with elective surgery, much less emergency surgery.
No.
So, so that's another factor.
Sure.
On the other hand, I think it is a big vessel. It's an important vessel, and it's got a very critical blockage in it. And going forward, I think it is going to put you at higher risk of having a heart attack. Sometimes what drives a decision is how symptomatic you are. If you're having constant chest pain and you can't get any relief, and done all we can with medications, well then you may be willing to take more of a risk to try to get a solution. Whereas when you're not having much in the way of symptoms, then it's a harder decision.
Right.
So I think those are the two options. I think the two options are just to put you back on your Coumadin, get your medications optimized, and see how you do. The other option would be to try to open up that blockage with the stent.
Doctor,
Correct?
go ahead, Daddy.
Yeah.
Go ahead, Daddy. Were you gonna ask a question?
Sure.
Go ahead.
It looks like the best thing would be for me to just not consider going
Yeah.
to
To bide your time.
to bide my time and not having a stent for the end of
Yeah.
complications
Right.
that at this age I could run into.
Right.
The medication route includes a modification of his current medications?
Well, we'll need to look at that and make sure that we have him on ideal therapy. The main treatment so far has been to make sure his heart rate is regulated. And that's very important, not only because of his atrial fibrillation, but also because of the mitral stenosis. People with mitral stenosis, they can do very well with moderate mitral stenosis until you kick their heart rate up. And then they don't do well. They develop congestive heart failure and they get sick. So, controlling the heart rate is going to be key. Some of the other things will depend on what his blood pressure is doing, whether he could tolerate other medications as well. Like, other options would be a beta blocker or long-acting nitrates. He's already on diltiazem, which is an anti-anginal drug. So there are some things we could potentially add, depending on how his blood pressure is doing.
And go back to the stent a moment. If you can put a percentage on this, and I know that's hard to do, percentage that'll work versus that it won't.
Right.
You mean with the stent?
Yeah.
Yeah, putting a stent in. Well, I think the risk of major complications would probably be around the order of 5 to 7%.
Okay, so there's definitely some risk there.
Yeah. Sometimes what we do in this situation where it's a high-risk lesion is we put in a circulatory support device. We've got a couple of different ways of doing that. There's a device called an Impella that actually goes into the left ventricle and it generates, it's got a pump on it,
Right.
and it generates enough cardiac output to sustain you through the procedure. The other is a balloon pump, which is a large balloon that goes in the aorta and expands and contracts with each beat. And that can help supplement your blood pressure and the blood flow down your coronaries. I'm not sure he's a great candidate for either one of those.
Yeah.
First of all, the Impella is not he wouldn't be a candidate for that because you have to put that across the aortic valve, and his aortic valve isn't healthy. So the balloon pump might be a possibility, but at his age, he's probably got a lot of calcification in his aorta, and we know he has some dilatation of the thoracic aorta. So, putting that big device in, he'd probably have a higher risk of bleeding or aortic complications from the procedure.
So if we don't do the stent, just do the drug therapy, change that or whatever, then he's gonna at some point have another attack, probably.
Probably, yep. I don't know how long. I don't know how long this blockage has been there.
Yeah.
You know, it could have been there for a long time. We've never looked before. And, you know, I guess the other, maybe the other thing that may sway you more towards medication is if he does start having more chest pain,
Mm-hmm.
then
Mm-hmm.
then you could make a decision to intervene at that point. Rather than now, and you've been here in the hospital how many days now?
I came out in early
Monday morning.
Monday morning, about
So far.
4 o'clock.
And your breathing got better pretty quickly.
Well, at first it did, and then about a day and a half, I was,
He had an episode about 12 hours after
After.
admission.
and I told them.
That might have been a heart attack.
I said, I need to have more oxygen, and
Uh-huh.
they did, and that took care of it.
Okay. It could be. I'll need to go back and look at, see when his enzymes started to rise and peak. Because I think they peaked pretty early on, and then, you know, so I think his troponins were highest when he first came in, and then they came down.
My impressions were that they were negative when he first came in.
Negative when he first came in.
That's my impression.
I wasn't here, so
Right.
That may be
Negative
right.
meaning there weren't any, and then the positive came later. So I'm wondering if that episode that he had at 1 p.m., 12 to 1 p.m. on Monday, might have been the heart attack, as we discussed earlier, brought on by the stress of
Mhm.
whatever else he was going through. You know. By the way, I didn't ask you if I could tape you. I'm not going to put this on YouTube. This because we won't be able to repeat this for the rest of the family. This is to show the rest of the family.
That's fine.
Is that
I don't have a
okay?
problem with that.
All right. Thank you.
I'm not holding any secrets.
Oh, you want me to put